So my name's Charmaine. I'm a social worker within the mental health liaison team at Gloucestershire Royal Hospital. Today we're going to talk about bipolar, and I have joining me is
Steve. I am a mental health nurse in the same team.
And I'm Katie. I'm a Lived Experience Practitioner in the mental health liaison team.
So as we know, bipolar disorder is a mood disorder that includes episodes of mania and depression.
So with bipolar, you've got the two, haven't you? It's a bi meaning two. I think it's important to differentiate bipolar from unipolar depression. You know, when people have just got depression, their mood just goes down, whereas with bipolar, their mood's going up, isn't it? And they're also getting the lows, and that their mood's going down as well. So it might be a good idea at first to look at those symptoms of the low mood that can accompany that.
Yeah.
So, you know, when you're thinking about going through periods of low mood, the symptoms of that are lacking energy, lacking motivation, your appetite goes downhill, doesn't it? Stop eating so much, and you know, lacking interest in those things that people normally like doing.
Their day-to-day kind of routine.
Yeah, so you've got all of those symptoms, which can obviously have quite a big effect on people's lives, can't they? If they're sort of feeling rotten and low, it can even be accompanied by suicidal thoughts and you know, there's levels of risk, aren't there, that go along with that.
Self-harm can increase, can't it? And yeah.
So those are the issues that come when people's mood goes down. But with bipolar, what differentiates that with people who've just got, you know, a depression is that mood also going up, isn't it?
Yeah, and it's quite an excessive sudden change, can't it? It's one extreme to the other.
Yeah.
And you can go between you can stay within a depressive episode or a hyper episode, or you can filter across the two, can't you?
Yeah, and with some people that cycle can be really slow, isn't it? With some people, you know, your mood can be low and
for a sustained period of time.
Yeah, and then you often see other people where those mood swings from high to low can actually be quite quick, can't they?
They can be, yeah.
Within a short period of time, you know, a couple of weeks or sometimes even less. So, you know, shall we look at what happens when the other side of things happens and people's mood starts to go up?
Yeah, so you can find there could be excessive spending. Aren't there, like which is out of character for that person.
Yeah.
So we've worked with people, supported people who have emptied bank accounts, booked cruises. I know somebody who purchased plane tickets to a number of different destinations around the world.
Yeah.
Bought a new car, all within a matter of an hour.
Yeah.
And wiped out all their savings. So that can be that. And also when we spoke about risk taking, when they're on a hyper mood, they can take risks with intimate relationships, can't they? And things like that. You can be quite promiscuous, maybe, put yourself in some risky situations. And then again, sleep, you can feel like you don't need to sleep. You can feel quite euphoric in mood, can't you? Or you don't feel like you need to sleep. But still feel really energised, still being really motivated.
Yeah. And I've seen people who, you know, looking at the risk side of things, when their mood's elevated, start to almost feel like they've got like superpowers.
Oh, yeah.
You know, like one example could be someone thinks, if I walk into the road, I'm going to be perfectly safe because the traffic's going to stop for me.
Yeah.
You know, I'm not going to come to any harm at all. And as well as relationships and making unwise decisions. And like you've said, spending money that they may or may not have. All of things which you usually find when someone is well again, looks back and sort of deeply regrets, you know, and relationships which are meaningful to them could have been damaged during that process, or money that they had or didn't have that obviously they're regretting spending or giving it away or whatever's happened. But I think when people's mood goes up, there's normally two phases, isn't it? You've obviously, if we say when people's mood is in whatever's normal for them and then it starts to go up, there are phases to that, and the first phase is called hypomania.
Yeah.
And I suppose from a mental health professional point of view, what we try and do is do care plans so that we and the patients can notice those sort of early warning signs of hypomania, so that then we can act to keep people safe and well and stop them getting to that stage.
And it's also important to include family in that as well, isn't it? Or people, somebody who knows that person the best, whether that be family or a care team. It's good to get them involved, isn't it? So they can help to notice those sudden changes.
Yeah, you're right. And those sort of things which people need to notice, it's different for everyone. But I suppose common ones to look out for is, say, sleep's quite a good one to look at, isn't it? It's like if people sort of, if what's normal for them is they normally like have a good night's sleep of 6 to 8 hours.
Yep, not me. I don't know about you.
No, not often. But yeah, if that's their sleep pattern, when their mood's starting to go up and they're going hypomanic, that might reduce.
Yep.
But, so they're managing on just one hour's sleep.
Or they haven't, or sometimes we often find they haven't slept for a couple of days. That can be, can't it? Yeah.
But unusually, and that's the thing to look out for, they're saying, oh, wow, look at me. I've only slept for an hour this week and I'm absolutely fine.
Yeah, I don't need sleep. I can take on the world.
Yeah, I can take on the world. I can think clearer than I normally do. I can produce more work than I normally do. I can do all these things, and I don't need sleep.
Yeah.
And those are the sort of things that sort of, are those early warning signs which make you think, oh we need to try and do something before things get worse, isn't it?
On a really practical level, when people are starting to feel quite elevated, they can forget really basic tasks like eating. Washing, because they're so busy with everything else that's going on in their mind that as well as not sleeping, they're also not eating, not looking after themselves, and not doing things that they would normally do within their day.
No, that's very true. Yeah, so it's noticing that's I suppose is a good one to sort of think about, is planning for those early warning signs, and to notice those so that hopefully by picking up on those, that the risks are managed and we're keeping that person safe and stopping it getting worse. So that's what we call the episode of hypomania, when the mood's starting to become elevated. And then obviously we reach the stage, if things aren't contained at that stage, we reach the stage which is called mania. And when people reach mania, or what we would call having a manic episode, I think that's when things just become a lot more obvious. It isn't just not sleeping quite so much. There are other sort of major signs, aren't there?
There are, yeah. So we've mentioned the excessive spending, the risk-taking with self-harm, haven't we, and things like that. Yeah.
And I've also noticed at those times people might start wearing a lot more sort of, I don't know, eccentric clothes.
Or they might not be wearing any clothes.
Or any clothes,
yeah.
Or walking, can't sit down for very long, might have what we call pressure of speech.
Yeah.
All of a sudden they're talking at a
very fast pace.
Yeah,
which could be difficult to follow.
Yeah. Can't sit down, might start. And I suppose this is where a manic phase links in with a psychotic phase, because when people are manic, that's when they can start suffering from delusional beliefs, sometimes having paranoid thought processes. Sometimes you might see people who aren't religious suddenly having really strong religious convictions.
They might even have the thought that a religious entity is communicating with them in some way, or that they've taken on that.
Yeah.
Can't they?
Yeah, definitely. So, and that's when, as well as sort of all those other things we've mentioned, that the risk taking can start getting a lot worse, and that's when the sort of spending too much money and not being so wise about major life decisions, or partners can all start getting involved. isn't it? So that's like a rough overview, isn't it, of bipolar with the sort of highs and the lows of that.
How would somebody with bipolar get diagnosed?
I think to be diagnosed with bipolar normally needs to have gone through a couple of cycles of that, where people have definite, it's looking at that history. They've got a definite history when they look back of feeling elevated in mood and low in mood, and that's been problematic. And when you can look back and see there's definitely been cycles going on that you're in a position when a proper diagnosis can be made.
And it's good to have the family background and family involvement in those diagnoses or in those discussions, isn't it?
Yeah, it really is. Because sometimes it only becomes noticed when things do get to the stage where people are taking risks, or either to themselves, and it's brought to the attention of mental health services. But sometimes when you look back, people have been through episodes of highs and lows which have been difficult for them, but have been able to be managed without involving sort of GPs or referral to mental health services.
So I've heard patients referring to themselves as having a diagnosis of bipolar 1 or bipolar 2.
Yeah.
Would it be worth just explaining the difference between those two diagnoses?
Yeah, they're terms which aren't used so often now, but the difference between bipolar 1 and bipolar 2 was bipolar 1 is where people have had at least one episode of low mood and one episode of mania, where they've been manic and things have been really erratic and chaotic. And with bipolar 2, it's where they've had that episode of low mood and an episode of hypomania, where the mood has gone up but hasn't reached what we would call that manic phase.
Is it fair to say that bipolar 2, or that low mood with hypomania, is sometimes harder to diagnose? It might go undiagnosed for longer because the person doesn't reach that state where they might enter mental health services?
I think so, yeah. I think you're right there, because I think, it's important for us to realise that all of us have days when we might feel happier than others or sadder than others. So, all of our moods change, don't they, on a regular basis? Sometimes for reasons, something's going on in your life. Other times we all wake up, don't we, and think, oh, God, I don't want to go to work today. I can't face it. I just want to stay in bed. But it's weighing up what's normal and what isn't. And a lot of the times people with bipolar 2 might just sort of discount it as just normal changes, when actually it's more severe than that, and it still is a risk, and probably they may well benefit still from receiving some help to try and manage that for them. So but it can go off the radar, can be missed.
So based on what Steve just said, how would somebody know when it's time to seek help if they were worried about elevated or low mood?
So I think it would be a case of if it's impacting on your day-to-day life. So conversations with family, they would notice a difference or a change within you. Neighbours might even highlight things that are different with what's out of character for yourself. So if you're struggling to go to work, day-to-day activities of finding them really difficult. And also if you are experiencing a level of mania, you would be more than likely being drawn attention by other services or by other people. So that would be a time when you needed to seek help. Also, if you're struggling, like I mentioned, to get out of bed, you're not sleeping, struggling with eating, which is completely out of character, there's noticeable weight loss, changes within yourself, then it would be time to seek help.
Thank you.
Okay, so is this a good time to look at sort of the treatment options for bipolar? I suppose the main answer to that is there is no one treatment for bipolar. There's no sort of this is the tablet that people need, which is going to sort all of that out. People with bipolar are normally treated with a variety of medications. And I suppose it's important to remember that everybody is different. Everybody's experience of bipolar is different, and the medications they need will be sort of tailored to what will work best for them, rather than there just being an easy answer to it. The medications most likely to be of benefit are, you've got mood stabiliser tablets. there's a range of them, so I don't think this is the place to start saying, you know, we
You should
use
try this
which specific
drug.
ones, because, like I say,
what would work for one might not necessarily
work.
Yeah.
So, you know, we could easily make you think, you know, oh, they've said on that podcast I need this, and that might not be the one. But yeah, mood stabilisers, generally speaking, are medications which help to keep your mood within more of I'm trying to think of the right word.
Stable?
Yeah, more stable. So yeah, more stable. So that you're not having the highs and you're not having the lows.
Fluctuations between the sudden changes within the moods.
Yeah.
The different
So you're more in that area. They work for a lot of people. There's also some people who actually quite like the highs they get with their bipolar, and are then not so keen on medication. But I think in view of the risks that we've already discussed, you know, if you're hitting those manic episodes, you know, quite often it is really important, isn't it, for treatment options to be really properly thought through and considered. Yes,
should somebody just stop taking medication if they're prescribed it for bipolar? I
think any changes in medication always need to be really carefully thought through, don't they? And any changes need to be made gradually and in a very careful way.
Which can be tricky, because when somebody is unwell, they might not. It's what's real to them at that time, so they might not believe that they need that medication.
Yeah.
They might and like you've explained, if they like the high, they might not be wanting to take that medication because they don't want the changes.
Yeah.
I think it's really important then that the clinician and the patient have a meaningful conversation about what is it that they don't like. I've come across people who say, I'm a really creative person, and when I take the medication I don't get those peaks of creativity anymore. And it's really listening to those concerns, and those kind of meaningful conversations help people to explore, you know, is this the right medication, and to take those concerns seriously. Because if you ignore the concern, that increases the risk that the person does go away and stop taking the medication.
So you've got your mood stabilisers. There are also times when antipsychotic medication is used. We're going to come on to more about psychosis in a while. But yeah, antipsychotics can help with those delusional beliefs, paranoia, and if people do go into psychosis, which is, you know, hearing voices and you know, what we're going to come on to. So yeah, you've got your mood stabilisers, your antipsychotics. Antidepressants may also be used, which will help people out of the lows. But again, they need to be carefully monitored, because anybody with bipolar, the risk if they're having antidepressant medication is over time that can actually tip them into an elevated mood or a manic phase. So again, that's where it's really important that that's really carefully monitored. It's needed at times, but potentially not all the time. And I think the fourth group of medications that sometimes is used is what we call benzodiazepines, which are medications which can just help to sort of calm people, particularly in useful maybe during the more manic phase of things, where people are sort of running around and really erratic, going at 100 mile an hour, thoughts going 100 mile an hour. Benzodiazepines can help to
Which is going to happen if you have got all those thoughts of rapid and you need to keep moving, you are going to be unsettled, aren't you? It's, like you mentioned, it's managing at those times, isn't it?
So I think that's often used as the first thing, really, when people are going through that manic phase, to calm people down, to help with sleep, just to try and look at stopping those thoughts racing, isn't it? So, yeah, it's not something which would ever be used over a long-term basis, but for those acute spells is often quite useful. So those are the four main sort of drug groups which are commonly used with this. So I think, is there anything else we need to say about drugs, or do you think that's basically?
I think that I think you've covered it. But again, mentioning that, you know, you shouldn't just stop taking medication if it's prescribed. You should speak to a medical profession before there's any changes with the medication.
we focus very much on medication.
Yeah.
And I think it's really important that we just widen that lens a little bit and talk about just briefly that, it can be really basic things like to prevent episodes of depression and elevated mood, things like sleeping well, eating well, having meaningful activity. And those are things that people will also be doing in the background as well as taking medication to stay well. And those are really important things that people need to be doing alongside the medication.
Yeah.
Otherwise, you just focus on the medical model, and we forget that there's a person there.
Yeah.
And helping somebody to return to work or to build relationships and doing all of those things that are going to help maintain stability in their mental health alongside the work that the medication's doing.
Yeah.
That's really important too.
Yeah. So what I did mention there was how antipsychotics can be used at times when we're looking at people who are going through psychotic phases, which can accompany the elevated mood. I thought it might be worth us looking into a little bit more depth about what it means, because that can be really, really scary for someone, can't it, when they start to experience the sort of worries and everything else that accompanies those sort of episodes. That normally comes along when people are manic, doesn't it?
It does, yeah, it does, yeah.
And I suppose...
And it's what's real for them at the time.
Yeah.
So it's understanding that that's their reality in that moment of time, and it's difficult when it's your core belief at that time. It's very difficult to make. You can't just suddenly tell somebody it's not real because they believe that is real.
It's real to them.
It's having that understanding, isn't it?
Yeah.
And that compassion, and yeah.
Yeah, and I think for people who've not experienced that before, that's when people's mood starts to go up. At first, that can be almost quite a nice feeling, like we've mentioned. They're managing with just an hour's sleep. Life's good.
Can get a lot done.
Yeah, get a lot done.
Yeah.
Everything's good, and then it can become that it goes through hypomania, and we reach that mania, where, for example, with mania, we've been through it already, but people might be feeling, in a much better mood.
Yeah.
Although they're going at 200 mile an hour.
Especially if they've experienced a depressive episode before that as well. If it's a sudden change, it could be better to be on the higher end, lower, couldn't it?
But then when you hit that manic phase, your mood can start cycling really quickly. You can be almost from minute to minute, things can change, can't they? One minute you're really elated, life's really good. A minute later, you might be in tears, feeling suicidal. Everything is really out of control.
Yeah.
And that is when, from what I've seen, people are more susceptible to that hitting that psychotic phase.
Yeah.
Which is where then things can become quite frightening, really. That hearing voices.
But bipolar isn't but psychosis also isn't always linked to bipolar, is it?
No.
It can be a separate, and you can have different episodes of psychosis, can't you? Yeah. And you can have psychosis for many different reasons.
I think that's a good point for us to end our podcast there on bipolar. If I could just add, in our discussions there, we were just coming on to where bipolar and psychosis sort of meets. So if you need to, we are going to do a separate podcast about psychosis, so you may be interested in learning more and listening to that one as well. But thank you very much for listening or watching to us today, and we'll see you soon.